you very much. So do we have other question? Okay, so we can move on, and we'll move from United States we come back to Europe, and now I will invite Cecile Monteil, that she works at the Pediatric Emergency Department of Hôpital Debré in Paris, France, to give her a presentation.
Hi, can everybody hear me okay?
Yes, very well.
Okay, great. Okay, great. So yes, I'm working in the Robert Debré Hospital. So basically in Paris, we have 3 major hospitals for pediatrics. Our hospital is only for children, and we also have a maternity. And we have at the ER about like 100,000 visits per year. So for the COVID-19, I'll try to answer the questions. We had to fully reorganize ourselves because we also welcome adults. So for the hospital, we used to have 2 separate entrances for patients, and one was blocked. So there was only one way to enter the hospital. And like in Boston, everybody is a suspect until proven otherwise. So everybody gets treated the same way. At the entrance of the hospital, we give simple masks to the child, and we allow one parent in only, except when there is a barrier language, if the mother wants to stay with the children and only the father can translate, or a friend, then we have to let that person in. Once they are at the reception of the ER, they are sorted out at the reception desk. If like usual, if the patient has serious symptoms, he's immediately put in the resuscitation rooms, and everybody is equipped like if it was a COVID patient. And otherwise, they are sorted out as usual. Urgent, semi-urgent, and non-urgent cases, and we have 2 sectors, a traumatology sector and a medical sector. Everybody's screened with the classic symptoms of coronavirus, and everybody gets to have a individual consultation room, because that's all we have in Paris, which is pretty good, I guess. We have no negative pressure rooms. We don't have that. And what we did was we allowed about half of the department for COVID cases. So those are consultation rooms with, it's a bit less than half, with a window. So we can, in between patients, we can open the window, and a PPE station next to each door. So usually the PPE, so everybody's wearing a simple surgical mask. That's for all the healthcare professionals. And because we've been having trouble getting enough PPE, only when we need to do something like a throat swab, or, examine the throat, or, really we are at high risk of being coughed in the face, then we put the N95 mask. We've been having face shields. They didn't arrive very fast, but we had a lot of help from 3D makers in industry who sent us some, so now everybody has one. So yeah, so the mask, the face shield, we have the caps and disposable gowns, which also we've been lacking of. So we try to be very minimalistic with all of the PPEs, and non-sterile gloves. And then of course we have hydroalcoholic gels, and we wash hands all the time. It was not easy at the beginning, because all the surgical masks and all the hydroalcoholic gels been stolen in the hospital. Like within the first week of the epidemic, everything disappeared. It was like thousands of masks, and there was no more bottle of gel. So we had to like lock them down and go ask for, one mask or hydroalcoholic gels. Every day when we come in, we have this little pocket with like 3 surgical masks inside, and that's all we have for the day. But it's been, it's been working fine, I guess. So after that, for the test, we only do the PCR for patients who are required to be hospitalized, regardless of the reason. That's because we don't have a lot of tests available. It took us weeks to have our own machines. We were supposed to receive some from the US, and then COVID went to the US, and then they didn't send us the machines. So we had to send tests in a different hospital, and we would have to wait more than 24 hours because even though the other hospital had machines, there was so many tests to do that you had a waiting list. So sometimes it would take several days. Now we have our own machine, which runs 3 times a day, except at night and on weekends. But we have very few tests, so we can only do tests for patients who are hospitalized, and we cannot test parents, and we don't test the healthcare professionals as well. They will only get tested if they have symptoms. Otherwise, you cannot get tested. So at the beginning, we had planned for 2 very distinct paths for COVID patient and non-COVID. We actually had a disaster tent, like a temporary tent that was outside on the outside of the ER, in case of I don't know if we were overflowing with COVID patient, but it never happened, so we actually never used it. And we had also marked a route on the floor with arrows, so the COVID patient would not cross the non-COVID patient, but we never used it as well because we went very fast from already coming back from China to just anybody can have it. So again, everybody was considered a potential COVID patient. For the human resources, so I think our total staff is, I don't know, 120 between the nurses and the doctors. We have about 30 doctors. We have 15 residents. So quite quickly, we had a lot of nurses and residents who left because they were reclaimed by either the military for the military residents, or because they were coming from a different area of France, and so they had to go back and help, in their cities. And the nurses, because we were lacking so many nurses in ICUs, we had nurses who went to help in different ICUs. But the thing is, because our ER was super calm. We went from having between 250 to 300 patients a day to having 50, maybe max 80 a day. So the activity was really down. So we were able to cut off a lot of people who are usually working, the residents. So more than half were gone, and we were still able to make the doctors work less. So that's, for the HR. Also, what happened in our hospital is, so like I said, we also welcome adults. So our pediatric ICU unit became an adult ICU unit, and the pediatric one was moved in a different department. We opened 18 beds for adults. We also opened a step-down unit, which was actually also for the patients. So basically, we were welcoming adults out of the ICU. We were welcoming pregnant women who required oxygen and were too unstable to stay in the maternity. And we were welcoming children, post-operative children who happened to be COVID positive because the pediatric surgery department was not equipped to receive COVID patients. So we also had that unit, which opened instead of the ENT departments. And so we had some of our doctors go to those units. So for example, for myself, I was divided between that step-down unit, seeing adults and pregnant women, and the ER. So the HR was it just became very, very different. It was not messy. I mean, it was organized, but it just, everybody was trying to go help everywhere. And also we went to help adult emergency department in other hospital. So yeah, it was the human resources were allocated a bit everywhere. So that's for the HR. So we had the ICU adult unit, we had the step-down adult unit, but we also had specific beds for COVID patients in general pediatrics. We had 8 beds, 8 rooms who were just for COVID patients. We had 4 beds in the hematology department and 1 bed in the psychiatric department. So to follow up with the question, how can you define a suspect case of coronavirus infection? Well, basically, it was every patient presented fever and a shortness of breath. How do you manage the suspect patients? So yeah, so at the beginning we had to separate paths, and we ended up just putting the COVID suspicion in independent consultation rooms with just like a window and the proper PPE. Which criteria do you use to define a coronavirus infected patient? So it was a positive swab. I know at the beginning the swabs were done only in one nostril, so we had to change and ask, you know, to do it in 2 nostrils for enough time, and we still know that we have probably a 30% rate of false negatives. So the test, as I said, now it's analyzed in our hospital 3 times per day, and we do it only for patients who are going to stay in the hospital. So sometimes we have the results in just a few hours, but sometimes we have to send it in a different hospital, and usually we have the results in the next 24 hours, which means that the patient who get operated on, we most of the time don't have the results. So every precaution is taken as if they were a COVID patient. When they get out of the operating theater, they go to a specific COVID department, and then when we have the results, they can either return to a classic non-COVID department, or they stay in the step-down unit, basically. So yeah, do we have any program of screening for parents or caregivers? No, we absolutely do not have enough tests, unfortunately. Yeah, what are the clinical pictures that you have found in children? So I don't have a good track of the number of patients that we've had, because we do so few tests, and all I know is that we've had very few patients that were COVID positive. I don't want to give a number. I can come back to you, but I would be scared to say the wrong thing. But I don't know. I would say maybe like 20, 30. Those kids, usually we had a few kids with severe. I mean, I think we have 2 kids with severe diarrheas. We had 2 kids with Kawasaki-like syndrome, who seem to be answering pretty good to the treatment with immunoglobulins, but yet their PCR were negative for the 2 children. So is it linked? We don't really know. We had a few kids with anosmia and a loss of taste. We had a few kids with exanthem, with skin rashes. We had very few fevers and respiratory discomfort. We had 2 respiratory distress in one patient had sickle cell and the other one had leukemia. Both recovered, and we're not that. I mean, we don't think the respiratory distress was linked to the COVID, and we've had no patient with neurological symptoms. But again, we do so few tests that it's hard to say, because very few patients have been hospitalized with the symptoms, and actually the politics changed, but for a while we were supposed to only test patients who were hospitalized with symptoms of coronavirus. Now it's been only like a few days that we have to test every patient that is getting hospitalized. So I think that, you know, it's really hard to make statistics when almost no one has been tested in a way. What we did notice is probably what everybody else saw, but because people are scared to come to the ER, we see patients that are much more serious than usual. We've been astonished to see super serious peritonitis, like they were coming in almost in a huge sepsis, almost dead. We've seen so many broken bones that had been home for like 3 days, 4 days. So yeah, that's what we noticed, like very few consultation, but when they do come in, it's pretty serious. And now that we're trying to pick up again, like an activity in the hospital, especially in the operating theater, people are actually refusing to come. So that's also becoming a problem. So I think I tried to answer most of the questions. I don't know if you have any other question.
No, thank you very much. We are exactly on time. 15 minutes, and so we can open this presentation for discussion. Do we have some questions to Cecile? For Cecile? I have a general question. Overall, among all the French population, which is the percentage of infants that are infected?
So because we have no test, I mean, I'm amazed to hear that in some hospitals they can test almost everybody, but we have no test, so we actually have no idea. What we see is, what we think is that there are actually few children that are infected, and usually they are infected because their parents are, and not the other way, which is the opposite of usual sickness in usual viruses in children. So we think it's a very small percentage, but it's hard to have numbers because nobody's getting tested. So how can, I mean, I'm sure we'll have better numbers and maybe, but to have numbers you need to test. So okay. I really wouldn't be able to say.
Okay, so